I do think that it is healthy for health systems, health providers, health tech companies to have the experience of other sectors. And oftentimes people think, oh, there's a lot of clinician power, doctors know best. And they're sort of like, oh, hands off, healthcare is complicated, I don't want to get involved. I think everyone should have a healthy degree of challenge. And I think in many cases, some of the reasons why we haven't moved as fast in healthcare in terms of implementing different technologies or standardizing things is because of that attitude of, oh, it's too complicated, we don't want to, mess with it. And I think it is complicated, but I don't think that means we shouldn't try.
Hey everybody, welcome to another episode of the Healthtech Podcast. This week I'm joined by Sara Siegal from Deloitte. Sara, welcome. How are you doing?
Morning, James. I'm very well. How are you?
I'm all right. I'm actually going on honeymoon in a couple of weeks. It's actually, I think, less than a week now. So I am desperately trying to clear the decks of all my work and hand things over. So a little bit hectic, but obviously a very joyous time. So looking forward to it greatly.
Congratulations. Where are you going?
Thank you. Going to the Seychelles. So we've actually got a month off. We're getting married in we've done like a small legal thing, but we're getting married in inverted commas in France, and then heading off to the Seychelles for a bit. But yeah, having to leave the business in someone else's hands for a little while, and all these exciting things that I've never had to do before. So yeah, it's an interesting time.
It's good for us. I think some people, type A people, when they go on holiday, think everything's going to fall apart. And then we learn that we're not that important after all.
It's so true. One of my, it's funny you say that, actually. One of my, I don't know whether to call it a concern or actually something that I'm looking forward to is coming back in that realization of, hold on a minute, this can work without me. So I think if that is the case, that starts to change things in my mind a little bit for how I spend my time.
Yeah, take it as a good thing.
It is. Yeah.
Relax on holiday. It doesn't mean that you're superfluous and that you're going to get fired.
Absolutely. Because in the process of handing things over, the list of stuff that I do with my days, I've just realized, like, why am I the one doing all of this stuff anyway? Once this is handed over, I don't actually need to be taking back like the admin inbox. Why am I managing the admin inbox? This is so bizarre. So yes, it will be quite interesting. Yeah,
sounds like a healthy transition work-wise as well as personal-wise for you.
I hope so. But this is not about me. This is about you. So delighted to have you on. Obviously a great leader at Deloitte in healthcare. And yes, been at Deloitte for 20 years. You obviously know that business inside out. So we're going to learn a little bit about Deloitte and what you guys are up to there. But yeah, it'd be great actually for you to tell a bit of your story. So how does one go about their working life to eventually lead Deloitte in healthcare?
Well, I think there's probably many paths to that, but I can tell you mine. So as you've probably guessed by my accent, I'm not from the UK originally. I'm American born. I was raised in Washington, D.C. And when I finished undergrad, I didn't really know what I wanted to do. I had gotten a broad-based liberal arts degree. And I thought, I'll just be a management consultant because then I can kind of shop around and all of the clients I get to work with and see what business I actually want to go work with for my real career. And so I did that. And I actually realized that I liked being a management consultant because I just loved the variety. I loved going into different businesses. I liked getting asked different business challenges. And I realized that actually that could be a career and I didn't have to pick a company. I could work with lots of different companies. But then I did have a couple of ups and downs that led me to healthcare. So no disrespect to the building materials company, but I did do a project for a building materials company where I spent 6 months negotiating freight tariffs for sheet glass in a basement with no windows. And I, 14 hours a day. And I just thought, wait a minute, like this is not how I was planning to spend my life. And healthcare was a stroke of luck. It was totally chance. I moved to London after business school and I said to the person in the office in charge of staffing people on projects, I said, just put me on a really big project because I'm new and I want to meet people. And I've got this very broad background. I've worked in financial services, technology, media, telecom, automotive, consumer products, academia. I had, a good sampling of projects under my belt. And he put me on a project working with the NHS, which I, at the time, was not familiar with, having been born and raised in the US. And I just thought, this is so amazing. The structure and how this is organized is just how wonderful for the citizens of the United Kingdom to be able to access healthcare free at the point of need, to not worry about quitting their job for fear of losing their health insurance, having no fear of, your long-term condition making you ineligible for, insurance or, have huge costs of care.
Which we take for granted, by the way, quite a lot.
It's just a very different mindset in the UK. It took me years to really get inside the psyche of how people think about healthcare in the NHS in England compared to how people think about healthcare in the US. And there are many views, obviously. But regardless, so I got put into this healthcare project. I loved the NHS and I asked for more. And then one of my early projects was working with the government to help them negotiate what at the time was called the PPRS, which is a profit maximization scheme. It's how UK government sets prices for branded pharmaceuticals. Probably know all this, James, but for your listeners.
I don't actually. It's really interesting.
Oh, okay. They've changed the title since then, but it's another really great thing that happens in the UK. So in the US, pharma companies set prices based on what they want to charge for their products.
I've been listening to a lot of Mark Cuban podcasts recently with Cost Plus, etc. So I'm fully up to date on the US pharma pricing system.
Yeah. And actually the US, the federal government, CMS, like my understanding is that they are now beginning to think about the kinds of constructs that have been implemented for many years in countries like England.
Interesting.
But what we do here is we ask all the pharma companies to come together as one behind their industry group, the ABPI, and to negotiate with the government. And it's not just a straight price negotiation. It's a very holistic negotiation about profit, about mix between products. And there's always avenues for investment in different categories. When I was doing this, and this was years and years ago, we were looking at categories like pediatrics and ultra-orphan drugs. And I mean, it was mathematical, it was analytical, it was psychological, and it was all, for the good of the population. And, you come to an agreement with industry. And at the time, I think it was something like 750 million pounds out of what at the time was like a 14 billion pound drugs bill was being reinvested back into these research funds for things like ultra-orphan drugs. And so I finished that project after the sheet glass project. And I was like, oh, this one, I like this one better. So basically, the long answer to your question, James, is I really fell into healthcare, but it's an industry that I absolutely love. And I love it because it's intellectually challenging and because the work that you're doing is to benefit mankind. And I've also, I've just always had a tacit love for human biology. I wasn't pre-med or anything, but it does allow me to kind of tickle that itch as well. I don't get to go as deep as my, scientist friends, but it puts me adjacent, which I really like. And it's endlessly complex. It's industry that I've been working to improve for 20 years, and we're definitely not done. So there's great work to do. So I feel very lucky that I stumbled into this and that I get to spend my days working with clients in this sector. And I just always feel like this is so cool. Like we're at the cutting edge of what's happening in the world. And we'll talk about, AI and innovation and all these things. But it is not a job where you get bored.
It's true, actually, and not a job where you ever lack purpose. Like you talked about, being a basement room negotiating freight tariffs and stuff. Like a lot of my friends say this to me, actually, that it's you don't ever need to question your purpose when it comes down to it, because you can follow the path to human good of what you do. It's been the case when I was a clinician. It's still the case now, although it's, quite a bit further away, but I can still follow that path. And I think it is something that I guess that I've certainly taken for granted. I know from my friends that have, investment banking and all the rest of it, like, yes, they take a nice paycheck home, but they do have this kind of like hole inside them that isn't quite being fulfilled, which is quite interesting. One comment that I did have on your background there, which I think is really interesting, is management consultancy, right? A lot of medics want to go into management consultancy. A lot of healthcare people want to go into management consultancy. And I think you kind of identified why there, because it gives options. Like you had options. It was a career that you chose initially because of the optionality that it gave you. It turns out you actually enjoyed the optionality and the variety in its own right, which is why you've stayed in it, obviously. But the thing that I think is really interesting here is that by the time you'd got to healthcare, you rattled off a list of the things that you'd done there: financial, academia, telecoms. These types of things, when you've already become competent and aware of what's going on in the world and have the ability to problem solve through those types of lenses, knowing what you know about financial management and academia, and being able to put all of those disparate skill sets together. And by the way, how disparate they are is not related to how important they are, because actually healthcare is all of those things still. We require the technologies from all of those different sectors to move into healthcare in order for it to become better. Healthcare still needs a payment system. It still needs to manage its finances. We still need business cases. We still need academia and cutting edge science to work correctly and actually be sat amongst everything else in the right way and working as a whole system. So what's interesting to me about one of the reasons that you've become, obviously, a leader in healthcare through Deloitte, I think, is because of the fact you've had such a varied background and you're able to apply it to healthcare. So my question, I guess, at this point is is that a fair assumption? Is that a fair analysis? Because my hypothesis here, if we're going to talk academically, my hypothesis is that leaders in healthcare could do with this type of education in finance and all the things that we actually don't like talking about, like profit and P&Ls and balance sheets and all the rest of it when it comes into healthcare in the UK. I just have this suspicion that that's what might set you apart when it comes to problem solving for a lot of your kind of provider organizations that you work with at Deloitte. I
mean, maybe. I have to say, I have a few thoughts on this, James. I think that's good for everybody, no matter what you end up doing in life. This is a slight tangent, but I just think that education doesn't really prepare us for life in many ways. And you have to figure out what's out there somehow. So, being a management consultant and sampling industries is one way. I don't know. I have a 13-year-old son. I plan from next summer to, make him do an unpaid internship in as many different industries as I can find a friend who works in, just to show him what's out there. And I just think it's helpful. I think the two most important decisions you probably make in your life are, what your profession is, how you're going to spend your days, and who your personal partner is going to be. And neither of those things are things that our education is really geared towards, if you think about it. So I think variety is really good. And especially because the world's changing so fast now, we have to I can't even tell my son what's out there. I don't think I properly understand anymore. I've been working, as you said, for Deloitte for 20 years. I'm pretty deep in one thing. But to the second part of what you said, I do think that it is healthy for health systems, health providers, health tech companies to have the experience of other sectors. I think for a couple of different reasons, healthcare tends to get pretty siloed and off on its own. And I think it has lost the benefit of the expertise of other sectors. I was really pleased to see, for example, here in the UK, NHS England putting people from consumer products and retail and financial services companies on its board, as well as clinicians, just to mix up the skill set and create what I hope will be a really rich conversation. But I think, and oftentimes people think, there's a lot of clinician power. Doctors know best. I know I'm saying this to a doctor. Well, and they're sort of like, hands off. Healthcare is complicated. I don't want to get involved. And I think that's wrong. I think everyone should have a healthy degree of challenge. And I think in many cases, some of the reasons why we haven't moved as fast in healthcare in terms of implementing different technologies or standardizing things is because of that attitude of, it's too complicated. We don't want to, mess with it. And I think it is complicated, but I don't think that means we shouldn't try.
Definitely. So Deloitte then. Tell me what you do at Deloitte. What does a day look like? What does a week look like? I imagine it's relatively varied. Who do you work with? What do you do for them? What's the exact job title and what does that mean? Talk to me about everything to do with Deloitte.
I have two jobs, basically. I run our healthcare practice in the UK, and I'm also our global healthcare sector leader, which basically means I try to bring all of our healthcare practices around the world, like our practice in the UK, together to collaborate where it makes sense. And that's a really fun part of my job because healthcare is a very in-country business. We're all working with hospital systems, governments, payers, Some of them have a multi-country presence, but for the most part, it goes country by country. So it's very different than, say, if your client is Citibank or Roche, who have presence all over the world. But what we do find in healthcare is that we're all working on the exact same problems for our clients in most countries. And we would like to bring them, very similar solutions that benefit from all of our great thinking. So, that is what I spend a lot of time working on. And what do? We help our healthcare clients in the payer and provider space to improve in a variety of ways. We help with process, cost, efficiency, productivity. We help with clinical redesign. We do a lot on technology. Most of our programs are big, complicated change programs that have a big digital component. And we build, implement, and run technology on behalf of our healthcare and human services clients around the world. So that is the biggest bulk of our projects are. And we do that with a really wide variety of partners. All of the big technology companies that will come to mind, we work with, and we have teams, skilled in their various software packages. And to your earlier point, we have a lot of dedicated healthcare professionals in Deloitte. Some of them are ex-clinicians. Some of them are people like me who fell into it. Some of them are PhDs, scientists, ex-NHS management, people. And some of them are people from other industries that just really understand a specific finance system that's being implemented in a health system. So we really pull from a wide pool of expertise.
One of the things that I think might be interesting to talk about at this point is the fact that obviously the NHS has been around for a very long time, and it sits on a lot of legacy systems. And, a lot of the frustration that we hear about the NHS, the whole fax machines thing, the whole letters thing, these kind of processes that aren't digital. The NHS is enormous, and there is no such thing as the NHS. It's made up of many, 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 many organizations that are relatively independent. I say relatively. They share a logo, they share some of the same things, but they don't often share the same standards or processes or even management structures or even job titles. And there's lots of things that are different. And I think people don't realize that some people don't realize that in order to change a system that is so analog to a system that is more digital will give all of this exciting health tech that we talk about a place to land. A lot of this starts with changing infrastructure and what's, I guess, called digital transformation. In order to do that, the NHS needs help. It can't just overturn all of its processes immediately with the staff that it has, because those staff are doing other things. Therefore, the NHS needs help to do so. It needs external skills and resource to design it, to help implement it. And then also, I guess, to manage the change itself, the change management of that, the human factors of getting people to learn a new system, the education, all these things. So it might be interesting to talk about maybe a fictional example or an actual example, if you can, but don't want to name the places, of like, what does that mean when an NHS provider asks you to do a big project that's along these lines? What is it? What actually happens, and how do you go about it?
I mean, an easy example would be the example of the electronic patient record. I think people know what that is. And that's a fairly common process. And we are still implementing electronic patient records in the NHS in 2024. And I'm really pleased that the government's putting a big push on getting everyone an electronic medical record, because everyone should have one. So a project like that can have a very long lifespan, because it usually starts with a business case. There's usually some challenge gathering the right amount of funding, because it's an expensive program and there's different funding sources, which we don't have to go into here. And so we would help with the business case. Funding would be down to the leadership of the trust, but we can obviously, advise based on our knowledge of the system. There's a selection process to choose a vendor. There's a very small number of popular vendors. They each have pluses and minuses. We work with all of them. trust would choose the vendor, and they can use us for as much or as little of that as they want to. And then there is, as you've already mentioned, James, a pretty significant lift, which is the implementation and the change management process. And that is super hard in terms of change in ways of working. It's super hard, as you say, because everyone's already super busy, right? They don't have time to do more stuff.
There's a lot of fear.
Or think about how they're going to do what they're doing differently. There's a lot of fear. And the other thing is when you come out the back end, like, it's not like when you rip a plaster off and then the plaster's off. Like, there's a lot of, healing that has to happen after go live. And I think people are really already exhausted when they get to go live. And so that can be a little bit of a sobering reality. It's kind of like when I had my first baby and then I was like, wait, I still have like 20 more pounds to lose. What? It's kind of like that. It's disappointing.
Whilst raising a newborn as well and dealing with all of that, et cetera, et cetera. So yes, it's an interesting comparison. Yeah.
Exactly. So I think, that is really hard. But it's important to stay the course because, there are benefits at the end. And I was in a workshop a few months ago with a young doctor at a central London hospital who had implemented one of these electronic medical record systems. And she was saying, it's so great. Now I'm at this trust. At the end of the day, I'm done. I don't have to spend 2 more hours writing things up and putting things in different systems. Like, it's all done. So she was seeing the benefit. Similarly, I've talked to other clinicians that are uncomfortable with it. They don't like the way it works. They find that it's, just doesn't work with their style. So, there's a lot of opinions out there about this. But the fact of the matter is it's table stakes for safety and quality in modern medicine. So we have to do it.
Yes. And we mentioned workforce there as a real significant player in the change management process. I imagine, he talks about fear. We talked about the extra time that's required. Like, there's lots of reasons that you need to hold the workforce up quite highly when you're thinking about these projects and thinking about what to do for them and with them and all that type of thing. Is workforce a problem that you also solve for these providers? Is that a specific category of I guess problems that people will come to you with? And if so, like, what's an example of that and how do you solve for that?
Yeah. So, workforce is an absolutely huge category. There's all kinds of work that we do on workforce. Some of it could be with the HR function itself. The NHS has a very manual HR function. One of the things we've been doing is getting NHS leaders together with leaders from other industries and sectors to say, how do you recruit? How do you train? How do you manage holiday and sickness, absence? How do you manage HR and talent issues, performance management, et cetera? What's manual? What's digital? What tools do you use? There's a huge opportunity for the NHS to streamline that function. That's one kind of category of workforce, I would say. Then there's just the really, really big task of there's not enough clinical workforce to do the tasks that are needed today. The clinical workforce that we have is, frankly, not getting paid enough, very frustrated and overworked, and don't have the best culture in the NHS in many cases. So there's a lot of work like that to do. What we tend to focus on in that really broad category of workforce is just how can we make it better for the workforce? So in a region, like we worked in a region recently where we implemented a staff passport. There were 7, major acutes and DGHs. Staff wanted to be able to move between different trusts. And we were setting up kind of a hub and spoke model for different specialties. And it would make sense for staff to be able to move between them, but they had different terms and conditions and lots of other, quite technical things that needed to just be harmonized to make it much more seamless for staff. So we worked on that. We work on the whole staff, bank, agency, labor conundrum with the NHS to help sort that out in regions. And, most importantly, we try to implement processes and digital tools to make the working day easier, both for clinical and managerial staff. If you ask a clinician, they'll say that anywhere from 30 to 50% of their day is spent on what they'll call clinical admin. And pretty much to a person, nobody wants to spend that time doing those things. They didn't get into it to write up notes or to write up the same notes in multiple places or to search screen by screen, for a scan that they can't find, et cetera. So a lot of the work that we do on digitization is to really simplify and make the day easier for clinicians and to allow them to spend more time face to face with patients, which is what most of them signed up to do.
It's really, yeah. There's like parodies of management consultants, right? Of like, you're not from the sector, you don't really know. Like, you'll say some big words, you'll change the logo, cut 10% of the workforce, and we'll take £1 million. Like, that's the kind of parody of the management consultant, right? But the fact that you've got fresh eyes, the fact that you've got different skill sets, is that the value here? And the reason I ask the question is because I think part of this is, I think there's so much going on. I've worked in these organizations. I've written business cases as a clinician to try and get certain things changed. And by the time it's gone through me, my senior, the clinical director, the board, the chief exec, like, that problem isn't actually the most important problem to solve. There's other problems. There's like different priorities. There's this, that, the other, and it just becomes really, really, really messy. Is part of what you guys do at Deloitte, because you do a lot of these projects across the NHS, is part of what you do actually tell people, like, this isn't the biggest problem to solve. You might want to do something else. Or do people come to you and just say, like, hey, we just need help here? Like, what is the biggest problem to solve? And do you then use your fresh eyes to figure out what the best problem is? Or is it that these organizations are actually relatively, I guess, targeted in like, no, I want you on this specific thing because this is going to solve our problem? Do you work across all of those different things, or like how specific do you get with helping people in those ways?
Yeah. I mean, maybe if I just go back to the start of what you were saying, I mean, I think we are outsiders. We do have fresh eyes, but I think the reason we can be so helpful is because we do understand. My chief medical officer spent 30 years, running a GP practice in the NHS. One of my health partners, spent 20 years as the coup at a major, Shelford Group hospital. So we're not totally outsiders. We do understand, how the NHS works. So, it wouldn't work if we just rocked up and said, like, oh, we digitized a bank, we can save the NHS. That's not enough.
Which, by the way, it's worth mentioning that though, actually, because I do think that is a stereotype. That is a stereotype that does exist, but perhaps not people in the know, but I know for certainly people who listen to this podcast, it'll be a stereotype. So I think it's important to mention that you guys are full of clinicians and managers and people that have done this for many years.
Yeah, because you have to have people who can peer with your leaders in the NHS. To go back to the electronic medical record example, that those programs have to be clinically led. The medical director and the exec board at the trust need to be on board. And the medical director needs to be able to say, to other clinicians, like, this is how we're going to do it. I need champions from every clinical specialty to join me in this, special training group. We're going to bring clinicians in from other places who are going to be doing at the elbow training with all of you. You need to welcome them as peers. And we need to be able to have that conversation credibly with them, with clinicians who have implemented these systems already. They're not going to listen to us.
Because trust is such a huge part of that change management piece as well, isn't it?
Exactly. And then to the last part of your question, it's a variety. I mean, oftentimes clients will ask a question. We get hired to answer a question, right? We can't say, no, I don't like your question. I'm going to answer this question. They're not going to pay us to do that. But we can say, like, especially if we have a good trusted relationship with a client, we can say, I understand why you're asking this question. Would it be beneficial to look at it from this angle or to pivot slightly? And have you thought about this? And, they obviously have to agree to slightly change the way they're thinking about things. But we can say, we did this other thing down the road and it worked really well. What do you think about that?
Yeah.
That kind of conversation does.
Whether it's EHRs or whether it's other improvements that you're making through technology and things like that, I imagine you mentioned working in sort of regions and thinking of things in sort of regional ways, which, you start to get more of the law of large numbers, and you're likely to, make more savings at scale when you're implementing things at that kind of level. I imagine, though, it must be, at least in part, a little bit frustrating to be able to see the future in one place where you've implemented something, knowing that scale bit within and across the NHS doesn't exist in any kind of simplified way. Can you talk to that a little bit?
Yeah, that's exactly right. And actually, one of my biggest frustrations, and I think one of the biggest frustrations of many people who work in healthcare in the UK, is the uneven and slow uptake of innovation. So, we implemented what's the equivalent of kind of an HIE or a Lycra, a data lake for one region in the NHS. And now they are using that to do all kinds of cool stuff. They've got some AI pilots running with one of the big hyperscalers. They have patient data visibility no matter where a patient pops up in the system across the whole region. And that's not the case in another region, an hour or two's drive away. And that's a shame. Similarly, you'll see, we're doing some work on innovation right now. You'll see some amazing innovations in some places. And you think if this little thing, this preoperative checklist for a non-complex hip, whatever, just like this little specific thing could be implemented everywhere. You can do the math. This would save the equivalent of like 2 full consultants and 3 nurses, over the course of a year if it was nationally implemented. These are people that we don't have, by the way. This is about finding space, to do the work that we need to do. This is not about, like, people always get nervous about, this is about headcount reduction. There's no chance of headcount reduction in the NHS ever, right? Like, we don't have enough people. We are like tens of thousands of people short, right? Every efficiency we make is to try to get more activity through and to try to ease the burden of the people that we do have working in the NHS. So just wanted to put that point in as well.
What do you think is gonna, of the projects that you're doing, you must see a lot. You must see a lot of different technologies and different implementations and lots of different things. Some of it might be like, the infrastructure stuff that, like the EHRs, the stuff that we can sit on. Other might be more exciting technology. But what do you perceive does the NHS need the most right now? What if you could scale something across everywhere would do the most in terms of making that dent on how we're going to get to a place where it is financially viable to still have an NHS? So I think that's what we're all worried about a little bit. Those of us that sort of look at the numbers and look at where we're going and have an eye on direction and things. Fortunately, you and I are in innovation where we can see other parts of the future too. But I think a lot of people look at the financial viability of the NHS as it currently stands and they go, well, is that 106 billion or whatever it is going to stretch across everything with the expectation rise and the aging population and the, expectations on prevention and this and that, the other. Like, I'm just interested in how you see that, how you see the world in those terms from your vantage point.
Sure. So that is the big challenge. And I think we'll get to AI in a minute, but if I leave that to one side, I think that there is more that we can do with what we have today, even without the really exciting things that are coming down the path very, very quickly. So one thing that I feel really passionate about is that during COVID, which was a very difficult time for everybody, good things did come out of it. One is, we built a lot of new tech and we upskilled ourselves as citizens and patients. And, during COVID, we all learned to sort of swab ourselves and how to package up our COVID tests and put them in the Royal Mail. And we had the app and we were able to upload our results. And, there was a lot of transfer of responsibility and power from clinician to citizen/patient. And I don't think we've maximized or built on that since the pandemic. Because so much work was done to put the infrastructure in place to allow that. The Royal Mail started doing pickups on Sunday in the first time in its 500 plus year history. Right now we have, special NHS stickers on Royal Mail boxes that do these, special deliveries. That's all there. We can use that for more. We can be doing more virtual screening at home for a variety of tests. Other countries do this. We actually have already got agreement to send all kinds of human tissue through the post, everything that we need.
Oh, wow.
And I won't mention the different kinds of human tissue, but there's a lot, And we have citizens in other countries that are doing, other things for themselves at home that we haven't tried here. In Australia, you're not going to believe this, women can give themselves pap smears at home and then send the sample in. So I just think we have a workforce shortage. We showed ourselves as citizens that we can do more for ourselves when it comes to, screening and diagnostics. I think we should be pushing on that. And, during COVID, we built an ordering platform that plumbed into all of our healthcare systems of record for recording these things. So I think, on the front end, not necessarily, prevention, but definitely screening. I think virtual diagnostics is a huge area we could push more on. Related to that, and I know the government agrees with me on this, the NHS app is an untapped resource. It needs some work to get to where I think everyone wants it to be from a usability perspective and in terms of how it's actually structured. But that could be, the portal to, again, a lot of citizen power and control in terms of an individual's healthcare journey. Whereas now, we really have to rely on professionals to do a lot of Q&A for us, to navigate for us. I think we could be doing a lot more of that for ourselves. So I think the whole using the tech we have available today to kind of maximize on citizen power when it comes to the things that citizens can do is something that I think we could do a lot. And that won't solve things, but that will put a dent in it.
It will. I love that phrase, doing more with what we have. I absolutely love that. What do you think is the biggest challenge to this? What do you think is going to be the biggest barrier blocker to actually getting this done? Or do you actually just perceive this as possible and happening?
I perceive it as totally possible. I think sometimes, and you've alluded to this, the NHS, even at the center, is almost too big to understand what capabilities already exist. It's a little bit, and I have it in Deloitte. I work in a big organization too, like right hand, left hand, we can do that. We have that skill set. Oh, that's amazing. It's almost just, it's a connecting the dots problem.
Yes, I agree. I don't know who to attribute this quote to, but the future's already here. It's just not well distributed is the quote that does the rounds, which it just feels so apt, doesn't it, for what's going on? Because I imagine that once you've just done a go live on a project with a new technology and it's working and everyone's happy, you just kind of think, wow, now what if this was everywhere? And that I know the health innovation networks in the UK, they talk a lot about spread and adoption. And I used to work at the HIN, the South London HIN, when I was at the Digital Health at London Accelerator, and the spread and adoption piece was huge. It was a huge part of the work going on there. Of how do we do it? How do we get it done? How do we actually? It's a really, really, really complex problem, I think. And it's interesting what you say actually about Deloitte and a big organization. I don't sit in a very small organization, just spreading information within an organization so that the whole organization learns something when one part of it learns something. At our level, it's person. So a person will go to an event or finish a project and learn something. And how do we disseminate that learning across 15 people? That's difficult enough, let alone when you times that by 100 and you're talking, 1,500 people, or the NHS, however many, 1 million people, whatever it is. It's incredibly difficult to do, and I don't think anyone's cracked it. But that could be a whole nother podcast episode. So I'm not gonna push you too much on that, or ask you how to solve that in a pithy 60-second response. But you mentioned it before, AI. Obviously, there is lots of excitement. There's a lot of trepidation. There are lots of emotions flying around about AI. There are, for better or worse, hopefully for better in many ways, we've had the explosion of LLMs, which has put this kind of, there's the older AI that people used to talk about, the machine learning and the computer vision and words like this. And now AI has sort of become synonymous with LLMs, because all of a sudden now we've got this front end to the almost entire ability of AI. We've got multimodal, or LMMs, large multimodal models now that can have images and text and this and audio and video, and it can do all of this stuff. We've got MedPalm 2 with Google. We've got there's just an explode. People are putting chest x-rays into ChatGPT and asking what's wrong with it and getting very varied responses. So there's a whole thing about how the public are now using this stuff, and it's a bit of a mess, all of this. So as someone that is probably sitting behind an inbox that is probably full of these questions, can I do this? Should I do that? Should we as an organization start doing this? Or I think as an organization, I'm a CEO of blah, and we should now be doing everything on ChatGPT. I imagine you're at the center of a lot of this stuff. So it's a very open question, but talk to me about AI and talk to me about LLMs.
I think it's very easy to start talking about AI and just talk about a use case. AI can do this. AI can solve this problem. And I think that is kind of the sexy and exciting front end. And we spent a lot of our time today talking about the problems we want to solve. So that makes a lot of sense. But I think the problem with going in like that is that you can't just implement a use case with AI. You have to think holistically about what you're doing and how you're doing it and how you're going to do it safely. And that means you have to think about, the various regulations. You have to think about the various risks you're running. You have to think about the audits, the safeguards, the checks you're putting in place. You have to almost put a framework around how you're going to think about AI before you run headlong into your first use case, which could be anything. It could be a digital avatar to be your assistant. It could be clinical coding. It could be a referral to triage tool. It could be a discharge plan. I mean, I can name 50 or 100, different there's so much. That's why it's so exciting. But the problem is we're not talking about supermarket retail here. If the baked beans get routed to Stoke, instead of Newcastle, that's a problem. But if we make a mistake in the NHS, it's an unacceptable problem, right? We're dealing with health and human lives. So we have to go a little slower and we have to get it right. And we can't use, the open LLMs on the internet, which is why it's so great that all the big tech hyperscalers are leaning into this. And all of the big, providers internationally, and I'll put my, global hat on for a minute here, are also leaning into this and training their own LLMs. And I think the whole idea of having partial proprietary LLMs, although they won't be, as large as some of the big hyperscaler LLMs, is still a great thing. Because you still have multi-million, patients and, times that by the number of records.
There's still enough data in the NHS to make a model quite useful, I think. Even with what we're collecting now, I think there's probably a lot.
Yeah, exactly. So I think, I feel so positive about this because of all of the, major investment that's going in, both from, government and public sector, but also from big tech. And I should mention little tech. I think some of the coolest ideas that have gone fastest, and you mentioned imaging already, our medical imaging, which is such an obvious use case for AI in healthcare. So I really think that the winning formula is provider systems and governments who understand this and who have put people who understand this in positions of power to lead, thoughtful coalitions on how to do this. And then those people or those teams are working with, really big clusters of teams, which might include a Deloitte, 5 or 6 small health tech startups with between, 5 and 20 or 100 people, a Google, a Salesforce, an Oracle, an AWS, whatever, working together. And I think also, having thoughtful conversations with government and regulators. I facilitated a panel in September, which was a very international panel with a lot of hospital executives from around the world and a lot of regulators from around the world. And it was a really thoughtful Q&A session with the regulators asking questions of provider leadership. What are you thinking about this? How are you engaging with your regulators domestically in your country? What do you want from your regulator? And not every regulator is going to be asking these questions, but I think in a situation like this where things are moving so fast, it's really important that we just have a really open book approach to here's something we're coming up against. This doesn't feel like it's been regulated for right now, but maybe should be. And just, having that honest dialogue, across the various players in the market. But I just think, my overarching view on AI is, it's a bit of a mess. A lot of people are going to make mistakes. A lot of people are going to lose money. But in the end, this is going to totally transform our industry.
Yeah.
And it is going to free clinicians up from the overwhelming burden of clinical admin they have today. It is going to elevate the transparency that we have for patients. It is going to allow people in countries with less developed health systems to have access to much higher quality information and help them improve their health. And it is not going to totally solve our workforce crisis, but it's going to go some way in taking the pressure off of the people that we have today. So I am overwhelmingly an optimist about this, but I have no illusions about how complicated this is or how long it's going to take, or the fact that there are going to be some ugly missteps, unfortunately, along the way.
Yeah. I think one thing that might actually be interesting to talk about is I spoke to there's a guy called Keith Grimes here in the UK who he does he's got an AI consultancy. He loves large language models. I did like a 2.5 hour podcast with him a couple of episodes ago. But I'm paraphrasing now, but he says that thinking about how you fire AI at problems that we currently have is actually a very reductive way to be thinking about things if you're trying to be optimistic. What instead you should do is think about how you would redesign the entire healthcare system around the capabilities of AI, because that is what makes it optimistic and interesting, and to truly understand the impact that AI is going to have, to truly appreciate that one day we will talk about a pre and a post AI world in healthcare. That's what you should actually do. Because if you reimagine everything from the consultations to the way that we move information to the way that things are communicated to patients, if you redesign everything with the capability of AI in mind, that's where it gets really interesting. I imagine, though, that when you hear something like that with a Deloitte and a change management hat on, that it's equal parts exciting and terrifying / there's going to be lots of work for us if that's the world that we're moving towards. But yeah, I think that is an interesting concept that we struggle. And you said it initially. The first thing that you said was along these lines, like when we try and think about how AI can solve the problems that we currently have, I think that is reductive. I think that is challenging, because it will be slightly square peg round hole, because we're gonna think about what it can't do in the exact way that we currently do it. It's like I heard Sam Altman say on a podcast actually that he was like, I just released this thing to the entire world that could all of a sudden, you could ask it anything and it would give you a perfectly eloquent, well, it's not perfect, but it would give you an eloquent answer. He was like, this was completely transformational for the entire world. And I look on Twitter and what does it say? Oh, it can't count. You're like, what? Like the world is focusing on the fact it can't count to 10, when all of a sudden you can ask it any question of human knowledge ever and it will generate an answer. Yet people are focusing on the fact it can't count. And I think that's kind of the thing as well that will happen in healthcare, and kind of is happening in healthcare right now, is that I think rightly so, we have a very high bar for what it needs to do. And so we are focusing on the things it can't do. But I think the really interesting thought exercise is how do you, what if you were to take a blank sheet of paper and redesign the entire of healthcare around it? I don't know if you agree with any of that.
Okay, yes, people love to throw stones, and that's something that we always need to just be on alert for. It's very easy to be the naysayer, right? So I totally agree with that Sam Altman comment. I kind of agree. I kind of disagree with the Keith Grimes assertion. I think AI is a tool, right? It's not the end all be all. So the point is, how do we want to take care of ourselves as human beings? Like, what should healthcare look like? That should be the question. Not how can we redesign healthcare around AI? Because something else is going to come after AI, right? I don't want to tear down the whole NHS and design it around AI. And then, I don't know, ZB comes next. And it's like, I don't know, the next AI times 100. The point should be like, our physiology is what it is. Our disease profiles are what they are. Like, how can we best take care of ourselves with our comorbidities and our behavioral issues and, the available medical technology and pharmaceuticals that we have available to us today using this tool. So I feel like I disagree because I think there's too much emphasis on AI in his restructuring. But I kind of agree, because I think if you were to just design a health service on Mars for the colony that's going to go there of human beings, you would use AI and other tools, and you would design something that looks nothing like the NHS, right? So in that sense, and maybe we can actually apply that in a more realistic way in a sub-Saharan African country that doesn't have all of the old legacy infrastructure and estates of the NHS, and we can do something much more digital, much more AI heavy. So I agree with him from that perspective, but I would be careful about just saying AI is everything. I think we are the point. Our health and well-being is the point. And let's use all the tools at our disposal, including AI, to help us solve for that.
Also, don't want to misrepresent him, because I did paraphrase that. So I imagine you'd probably agree with that. I might introduce you guys so you can have a chat.
We could do a panel.
That'd be nice. Yeah, that'd be really nice, actually. Yes, I'll work on that. The other thing I wanted to just mention there as well, when you were talking about AI, you used a really interesting group of words. You talked about teams, You talked about clusters. You talked about coalitions. You said the word open. You talked about, we need to go a little bit slower. You mentioned there's lots of questions. It's very collaborative, what you're talking about here is like the way forwards with AI. I think that's it's just an interesting note about the way that you answered the question, that you obviously have, well, you tell me, you clearly have this idea that no one goes alone with this and gets very far. And it might be to do with the size of the NHS and healthcare in totality, that this isn't going to be one company, one winner. It has to be a group of people that come together to move this forwards. And I think by definition, it perhaps goes slower. But yeah, is that your feeling then?
Yeah, but I think the reason I say that is because we don't all have perfect information or full skills, right?
Yeah.
Like we need the big tech companies and the hyperscaler for the amount of investment and the skill sets they have that they can throw at this. They don't have the deep industry expertise that you have or I have, and they won't have also thought of like the really cool little like point interventions that some of our health tech startups will have thought of. And they, and none of us will have the regulatory expertise of, the regulator or regulatory experts. They'll say, if you're going to do this, you have to do it in this way and document it in this way and make this auditable, et cetera. So you have to work collaboratively because no one person or team has all the ingredients. And I know, when we develop tools in-house, it's always from someone who's been working on an NHS project. They've seen a problem. They know how to solve it with some bit of technology. But we always say, like, yeah, we could do that, but like bring a client with you. Like, I don't want to build something in our dark room and then be like, ta-da, to the market. Everyone be like, yeah, I don't know what to do with that, So that is the point about being open. Like if we're going to build something for anesthesiologists, like I want a team of anesthesiologists sitting in the dark room with me saying like, I wouldn't use that. It doesn't work like that, when I'm an operating theater. And that's why innovation has to be iterative and open.
It's worth drawing attention to actually. It's not only the stuff that we talked about that Deloitte does, you also have the capability to build, which is really interesting. So I guess as a healthcare team, like how much of the business is that element, and what sort of things do you build or are you comfortable building?
So we've been building small things in the category of software as a medical device and AI to use in our larger programs. It's not something which is ever going to be a big driver of our business, but we wanted to have that capability to understand how to do it, how tricky it is, how long it takes, how hard it is to implement and integrate, what the regulatory requirements are, so that when we're doing big projects around this, we understand what we're talking about. And we can work credibly with the big hyperscalers, our clients and health tech startups who are going to do this in a much bigger way than we are. So I would just see it as, an accelerator component of our practice.
Yeah, okay, that makes sense. And I guess my final question is that there'll be lots of health tech companies listening that might want to work with Deloitte in some way. What are the ways that you do work with health tech companies, and what do you require of those health tech companies in order to work with them in those different ways?
Yeah, sure. So, unless you're a very, very large health tech company, you're probably not a direct client of ours, but you can be a collaborator and a partner. And we do find ourselves working with a really large number of health tech companies, depending on what the client ask is. I would say that most of our projects are not just Deloitte plus client. It's, Deloitte and a consortium of 2, 3, 4, 5 other companies usually, because you don't hire Deloitte if you have just like a simple, performance management, productivity, or accounting question. You hire Deloitte if you have a big, hairy problem that, needs digital and there's a tax implication and then there's change management. It needs a lot of skills to bring the heft of our firm, right? We understand that. But what happens is when you have a big, hairy problem like that, it sometimes needs even more than a big firm like Deloitte. So we always partner for specialist input. So yeah, we find ourselves working with all different kinds of companies all the time. And actually, it's really back to my very first answer to you, James. It's one of the great things about the job is that you get to work with all these different companies. You get to work with small companies. You get to work with product-based companies, with service-based companies, with other professional services firms, and see, what they can do and how different they are. And it's that kind of, variability and variety that I just find so interesting. And that's what keeps me learning.
Beautiful. Before I let you go, my final question would be: I think you have a relatively unique vantage point to the healthcare system because of the variety of companies you work with, actually providers that you work with. You're at the intersection of seeing what's actually possible, what's actually doable from the adoption perspective, but also from the technology perspective as well. You're seeing quite a lot of everything going on. What is something that you're just genuinely excited about at the minute? It can be a small project or a particular technology or even just a vibe that's going on at the minute. But what do you think? What would you say is the most exciting thing for you currently in the healthcare in the healthcare system?
So I'm not going to name names, but some of the AI demos for health that I've seen from one of the big hyperscalers are so exciting. And if you think of some of the really frustrating bugbears of the NHS, like University Hospitals Leicester, they have translation services for 27 different languages because of the diversity of their local population. Sometimes if a person calls 111, they have to wait on hold for between 10 to 15 minutes until the translator with the right language skills can be put on the call with them. That can all go away. We can have, momentarily, things verbally written, translated in any language. We can have them on an app. We can have them shared with our, nominated friends and family members. If we have an elderly relative who people want to keep an eye on, like we can have summaries of our notes put into layperson terms. We can have the key prescriptions called up. There's so many things that we have the ability to do now that with the right, checks and safeguards we can implement that are going to change both the clinician and the patient experience for the best. So I just think, give it 18 months, 2 years, 3 years, like it's going to feel so different in a good way.
I love it. 18 months is optimistic. I love it.
Small change in 18 months.
Yeah,
we're on the road.
I would say you're an informed optimist. So I love that because you work at the adoption frontier, basically, which I think is very rare. So it's definitely good to have you on from that perspective and to display that optimism. So listen, it's been an absolute pleasure. If people want to get in touch with you to learn a little bit more or to ask you a question or they want to learn more about what Deloitte's up to, what's the best way for them to do so?
The easiest way is actually LinkedIn. My details are also on the Deloitte website, but I'm always putting things on LinkedIn. I love a podcast, so I'll repost this podcast to my LinkedIn. We also do a lot of research in the health space and the health tech space, which I'm always posting on LinkedIn. So you can direct message me there. And love to hear from you.
Perfect. Absolute pleasure. Thank you.